Hello everyone, I am Dr. Wafaey Badawy, a senior consultant histopathologist and head of pathology department AKMICH I am going to talk about germ cell neoplasms of the ovary, Yolk Sac Tumor. General background. Yolk sac tumor, endodermal sinus tumor, represents approximately 20% of all ovarian primitive germ cell neoplasms. It is the second most frequent after dysgerminoma. It usually occurs as a pure form or rarely as a component of a mixed germ cell tumor. Pure yolk sac tumor typically occurs in children, adolescents, and young adults, with a mean age at presentation of 19 years. Yolk sac tumor in adults occurs almost invariably in the setting of a somatic epithelial neoplasm, such as serous carcinoma, endometrioid carcinoma, or carcinosarcoma, which harbors a yolk sac tumor component. These lesions are referred to as somatic yolk sac tumors and are biologically different from pure yolk sac tumors. Like other germ cell neoplasms, this tumor presents as a rapidly enlarging mass associated with abnormal serum markers, particularly alpha-fetoprotein and CA125. Hormonal imbalances may occur, amenorrhea, virilization. Gain of chromosome 12 isochromosome 12p has been documented in most yolk sac tumors of the ovaries. It is usually associated with a favorable prognosis due to chemosensitivity with complete cure in more than 80% of cases. Gross appearance. Pure yolk sac tumor is solid, yellow tan with a heterogeneous appearance. It has focal myxoid gelatinous areas as well as small foci of hemorrhage. Microscopic features. Yolk sac tumor shows a variety of architectural patterns that are admixed in varying proportions. The architectural patterns include, in order of decreasing prevalence, microcystic reticular pattern, myxomatous pattern, solid pattern, endodermal sinus perivascular pattern, it is called Schiller-Doval body, glandular alveolar pattern, macrocystic pattern, hepatoid pattern, papillary pattern, sarcomatoid spindle cell pattern, parietal pattern, polyvesicular vitelline pattern. These morphologic patterns resemble the embryonic yolk sac, allantoid, and extra-embryonic mesenchyme. Please note that there is some data suggesting that the presence of certain histologic patterns is associated with resistance to chemotherapy, late recurrences, poor prognosis. These include glandular pattern, hepatoid pattern, parietal pattern, sarcomatoid pattern. Prominent polyvesicular vitelline pattern is associated with more indolent behavior. Microcystic reticular pattern. It is the most common architectural pattern in yolk sac tumor. There are interconnecting ribbons and cores of tumor cells enclosing round, irregular extracellular spaces and creating a honeycomb-like meshwork. The tumor cells have large intracellular vacuoles, compressed nuclei, and delicate strands of interconnected cytoplasm, creating a spider web-like arrangement frequently containing hyaline globules. Myxomatous pattern. It is one of the most common architectural patterns and closely related to and usually coexists with microcystic pattern. There are scant numbers of stellate or epithelioid tumor cells that are dispersed individually or form strands in a vascular myxomatous stroma. These cells are pluripotential cells and can differentiate into mature tissues such as cartilage, bone, and skeletal muscle. Solid pattern. It consists of polygonal tumor cells with abundant pale eosinophilic or clear cytoplasm arranged in solid nodules. The tumor cells have distinct cytoplasmic membranes and pleomorphic nuclei. Solid pattern can mimic seminoma, however, the fibrous septa and lymphocytes of seminoma are absent. In addition, the cells are more pleomorphic than those of seminoma. In difficult cases, immunostains can help in differentiating between the two entities. Solid pattern. These two photos show several small cellular modules at the margin of typical Sheila-Doval bodies. Plastima-like foci within the solid area can be seen and is composed of small round blue cells. Endodermal sinus perivascular pattern. Sheila-Doval body. It is seen in approximately 30%. Sheila-Doval body is a hallmark of yolk sac tumor, but it is not required for diagnosis. It shows a fibrovascular core with a single central thin-walled vessel in a hyalinized stroma, surrounded by one or more layers of cuboidal tumor cells with clear cytoplasm. The pseudopapillary structure is contained within a cystic space, lined by flattened cells. These two images show numerous Sheila-Doval bodies. Yolk sac tumor is composed of primitive cuboidal 2-columnar cells with abundant clear cytoplasm and large round hyperchromatic irregular nuclei with prominent nucleoli. Mitotic activity is usually brisk. Glandular alveolar pattern. The glands often show enteric differentiation, but lack a smooth muscle layer, unlike the glands with enteric differentiation in a teratoma. Macrocystic pattern. It often coexists with microcystic areas. It consists of large irregular spaces that form by merging of several microcysts. They may be empty or contain myxoid material. Hepatoid pattern. It is seen in 20 to 40% of cases. The tumor cells are polygonal and strongly resemble fetal hepatocytes. They have abundant eosinophilic cytoplasm and vesicular nuclei with prominent nucleoli. They are arranged in solid sheets, nests, or trabeculae. They contain hyaline globules, as seen here, and are strongly positive for alpha-fetoprotein and hepatocellular markers. This photo shows a small focal aggregates of polyhedral eosinophilic hepatoid cells in an otherwise typical lesion. Hyaline inclusions. Intracytoplasmic and extracellular bright eosinophilic hyaline inclusions are a constant feature of Yolk sac tumors. It is not a specific feature. These inclusions are PAS positive and diastase resistant and have been shown to contain alpha-fetoprotein, basal lamina material, or other plasma proteins such as albumin, transferrin, and alpha-1 antitrypsin. Papillary pattern. There are delicate papillary structures with or without fibrovascular core and a single layer of cuboidal to low columnar cells with hobnail appearance. The papillae project into tissue spaces. Parietal pattern. There is large amount of dense eosinophilic basement membrane material surrounding individual tumor cells or groups of cells. In extreme cases, the tumor is hypocellular and consists of only scattered neoplastic cells in an abundant eosinophilic matrix. This pattern is rare and is seen more commonly after chemotherapy in metastasis or late recurrences. Polyvesicular vitelline pattern. This uncommon pattern is characterized by multiple pear-shaped vesicles lined by flattened to cuboidal bland tumor cells, surrounded by loose myxoid or fibrous stroma. Some of the vesicles have constrictions creating a dumbbell or figure of 8 appearance. Rhabdomyoblastic differentiation. The cells of Yolk sac tumor are pluripotential cells and can differentiate into mature tissues such as cartilage, bone, and skeletal muscle. These images show rhabdomyoblasts admixed with microcystic areas in a Yolk sac tumor. Somatic Yolk sac tumor. This photo shows an endometrioid carcinoma with squamous morular differentiation, upper right aspect, merges with a more atypical and striking pseudopapillary population, lower left aspect. The yolk sac component is positive for SALL4, whereas the endometrioid component is negative. Conversely, the endometrioid component is positive for EMA and PAX8, whereas the yolk sac component is weak to negative for these markers. Somatic yolk sac tumors are highly aggressive and associated with poor outcome. Immunohistochemistry. Yolk sac tumor shows cytoplasmic positivity for alpha-fetoprotein, glypican-3, pancytokeratin. Yolk sac tumor shows diffuse nuclear expression of SALL4, GATA3, myogenin. It indicates somatic transformation into rhabdomyosarcoma. Please remember that immunohistochemical profile of yolk sac tumor. Both glypican-3 and alpha-fetoprotein are useful diagnostic markers of yolk sac tumor. Glypican-3 is more sensitive than alpha-fetoprotein, 100% positive versus 80% positive. Important negative markers include CD30, OCT34, a combination of SALL4 positivity and OCT34 negativity is considered to be highly specific for yolk sac tumor. Prognosis and therapy. Management includes surgery, which can be conservative at least initially, followed by cisplatin-based chemotherapy. Stage is the most important prognostic factor. Overall survival with chemotherapy is more than 95% in patients with stage 1 and 2, and 75% in those with advanced disease. It shows complete cure in more than 80% of cases. Extra ovarian spread occurs in approximately 33% of patients at presentation, usually to the peritoneum, lymph nodes, abdominal viscera, and lungs. Tumor recurrence may occur many years after initial diagnosis, requiring long-term surveillance. Compared to pure yolk sac tumors, somatic yolk sac tumors are highly aggressive and associated with poor outcome, largely driven by the carcinomatous component. These are the references. Thank you.